Hey guys, Don here. Welcome to Podiatry Practice Mastery. I'm going to go over the $1 Million Minute. I think I forgot to say a little bit when I was doing my report from yesterday, which was from Friday. I had some extra New Year's cards. We do a New Year's card to all friends and family, and so I had these extra ones. And so what I decided to do is I gave them to all of my patients on Friday. So because these are the ones I really like. These are the patients that I know. I know some people, and I talk a little bit about trying to reduce routine care, but these are the ones that know my kids. They've seen them grow up. They ask for what they look like, and so these patients, they really appreciated getting these cards. So just something to consider. That I did because I had extra cards, and I gave them to all the patients that came in. I think I have a few more left that I'll give out next week. So it was kind of a fun thing to do, and they kind of look at the kids' pictures and stuff like that. If you want to see what my kids look like, you can send me an email. I'll send you a picture. Okay. The idea is that this is a recording from my workday on Monday. There was a question that someone asked me. Some of these podcasts are I'm talking about some other things that visually, if you want to see anything visually, I'm usually posting it on the podcast, but I'm also posting it on YouTube. So some of these that I'm actually verbalizing, I think there was one on AI. Those are also going to be on my YouTube. Some of them might be in Podiatry Practice Mastery. So if you just go to my YouTube, you can look at all the videos in there, the video components of it. Okay. I want to talk about a quick concept here that I recognized recently in the office. The concept is called need to believe. And this, as a lot of my concepts I get from different people. This is one from Alex Harmozy. He's like kind of a marketing and sales guru. But I like the idea. The reason I was thinking about this need to believe is for patients to do different steps with us. There's a need for them to believe us, and how they get there's a couple of different ways. So let me give you an example. So I had a patient yesterday. They had insertional tendinitis to the posterior tibial tendon, kind of in the navicular tuberosity. They had a new standing job with daycare, doing a lot of standing, playing around with kids, things like that. It really hurt. So what I think would really, really benefit them would be Shockwave, okay, and Orthotics. The challenge is the need to believe right now is too great for them to go right into Orthotics and for them to go right into Shockwave. They have too much of they have other things they're not aware of. They're not aware of Shockwave. They're not aware of what Orthotics they were, but Shockwave they weren't. Okay, so what we tend to do, or what I've learned, is that I have to do some initial treatments to get their belief up, to educate them, to teach them, and then I can go to the next phase. So let me give you an example. So this patient, they got a cam boot to kind of rest the foot. Insurance covered it, so kind of build some credibility. They got meloxicam, they got the icing and contrast baths, and they're going to rest it for a couple weeks, then I'm going to see them back. Then I also sent them a link to an article on this kind of insertional, flat foot, posterior tibial tendinitis type of thing. So they're going to read about that, hopefully, or at least I taught them about that. Then when they come back, their need to believe, okay, well, we tried these things that insurance covered, they didn't work, and now we're going to go to the next phase. So they've kind of done the traditional things or the non-invasive things, and then we're going to go to the next thing. So I think this happens over and over. What's the way that we could kind of circumvent this? So, for example, if this patient had already seen someone else before, and they had got the walking boot, or maybe they got a cortisone injection and they didn't get better, and I was the second opinion, then I could jump right to the more advanced treatment, because the need to believe was low because they'd have already seen someone else. Another way you could circumvent it is if you were able to position yourself in a better place. So, for example, if they got some information about this condition and they read everything about it and had a book on it and some videos on it, and they watched everything, and then they came in and they had tried some of these other things like resting it, and they bought a boot on Amazon, like I recommended on the blog that they were going to read, then they're already on second base. So their need to believe was less, and they're ready to jump right in. Does that make sense? So I think many times we try to push the envelope and push too fast where we have to get over it. They have to believe one thing, then they have to believe another thing. So like the first thing they have to believe, which kind of go in order here, the first thing they have to believe is they need to see a doctor, right? So with foot pain, many times they'll go to their primary care. So they're in the wrong place. And so then after the primary care doesn't work, then they're going to, maybe they might send them to physical therapy. So they're still not to us yet. So they have to go through the physical therapy. Then that doesn't work. Then they come and see us. So the way of getting people to us directly is to educate them, is to get something in front of them where it explains their condition. So I just thought it was kind of a neat idea. And I think that's part of the reason why I have a two-step approach for nail fungus versus just a one-step. Like when they come in, like I know that nail is fungus by looking, not all of them, but some of them, and I could just start with everything. Hey, you're going to need to do the Lamisil or whatever you're going to recommend, but their need to believe is too great. They need to kind of believe I know what I'm doing. So that's why I take the nail sample. That's why I send them educational resources. I go over the different treatment options, give them my treatment checklist or my treatment sheet, and then they come back in 3 weeks and they're ready because they believe, because they've looked at some of this stuff, or at least they know I know what I'm talking about, and then they're able to go with what's recommended by me. Okay, that was kind of a long rant. Probably should have been a separate podcast, but let's go into the day here. This first patient was a 68-year-old man. He had foot pain. He was back. He is feeling much better with his foot pain, got new x-rays, and I did a nail sample because he was concerned about nail fungus, so he'll be back in 3 weeks. His foot pain is basically better. Another patient was a matrix follow-up. He was feeling better, so no need for follow-up. I'm trying to figure out a way of not having matrices come back. I was talking to a patient, another doctor at a recent AAPPM, and he said, yeah, none of my matrices come back. And I would like to know, does anyone not have your matrices come back? I'm thinking about it. I went from a 2-week to a 3-week, but like I'm never doing anything at that 3 weeks. So what I'm thinking about doing is putting a page or giving people out a page that has like visual examples of what things should look like at like, I don't know, week 1, 2, and 3, and show the skin sloughing and everything else like that. So maybe I can avoid it and just say, hey, I'm not going to see you back unless you have a need, or if there's a concern. And here's probably the best way is just to text me a picture and I'll say everything is okay. Now, occasionally I'm trimming some stuff out of the edge of the nail. I'm having to curette some stuff out, but not all the time. So it was just something I'm trying to figure out. Like, can I reduce this low-level visit, that for practice? Another patient was a new patient, needed a partial nail avulsion, bilateral, I think both edges of a nail, and he had a possible fungus, so I took a nail sample. He'll be back in 3 weeks, not for the nail avulsion, partial nail avulsion, but for the nail sample. Another patient came in. This was a friend that texted me some pictures. He had some Raynaud's, and I've been seeing a lot of this during the winter here, and I have a presentation I show them, and so they can see similar pictures of like chilblains, Raynaud's, things like that. He could see the dark discoloration in the toes, just encouraged him, and I said, everything was going to be okay. So he came in. I think they did get x-rays just because my staff gets x-rays and everything, which is kind of a good thing. So if you train your staff to get x-rays and everything, then like if he came in and I saw the Raynaud's, I wouldn't have got x-rays, right? Because I know what it is. But since they say foot pain, they're getting x-rays for everyone. Another patient, this was an MVP. This was a 73-year-old man. Been dealing with a ulcer between the third and the fourth toes. The toenail got a little bit long on the fourth toe with a kind of a curvature hammer toe rubbed into the third, and that thing is just slow to heal. Not the best circulation, second digit amputation, has a BKA on the other side, and so I'm just trying not to let this thing get infected. But it didn't work the first couple of weeks. I put him in a surgical shoe, and he's spacing the toes, and I'm going to do a collagen. So we got the 15-day collagen kind of kit. So the collagen reimburses very well. It's a little expensive, but it reimburses really well. Next patient was a patient that was here for ankle pain, and they also had here for plantar fasciitis follow-up. So what we did for this patient, ankle pain and plantar fascia were on the same time. She had previously got 6 Shockwave sessions by my colleague. Now she had ankle pain. She had a lot of equinus, so I got x-rays, put her on meloxicam, did an ankle injection to calm that down, and I did an ultrasound that showed thickness of the plantar fascia. So most likely when she comes back, I'll do Shockwave at the next visit. I think she got tighter. The equinus was kind of the culprit because everything is kind of tight in there. Another patient was quick follow-up for matrix follow-up. There's another patient that was a matrix follow-up. Once again, all these matrix follow-ups that are filling my schedule. But actually, they're filling it on a day that I'm not as busy, so that was okay. Another patient, scheduling EPATs 1, 2, and 3 for the second time. And then another patient was a first met cuneiform pain. This was a 92-year-old female. She had a stacked Hoka shoe, and she went down to a zero-drop shoe. I think the problem was the stack, okay, for this patient. Of a shoe, and then I didn't do really much of anything. This is the posterior tibial tendon patient I was talking about. And then the last patient was a EPAT. I set it up number 4, 5, and 6. She had been 1, 2, and 3 for the second med head. So hope you guys found this beneficial. Let me know how your practice is going. Thanks.